Hello, my name is Ann Washburn, and I'm the Administrative Director of Community Relations and Affiliations at the Vanderbilt-Ingram Cancer Center. On behalf of my colleagues at VICC and Susan G. Komen, Central Tennessee, I would like to welcome you to the Breast Cancer Research and Resources during COVID-19 program. We are so thrilled to have Dr. Ben-Ho Park from our Cancer Center and Don Eaton from Susan G. Komen, Central Tennessee to share their expertise and resources. The goal of this evening's program is for you to learn more about breast cancer research and resources, especially during this unprecedented pandemic, COVID-19, and to have the opportunity to ask questions. At this time, I'm going to review a few housekeeping items for consideration. We would like to ask you to please share your camera if you're comfortable. It's not required. Please keep your mics on mute when not talking, and you'll have the opportunity to speak during questions and answers later. Please note that this program is being recorded because we want to ensure that we can share this expertise and information with others who cannot be here tonight. If you have questions during either Dr. Park's or Don's presentation, please write it in the chat box. We will be looking at that, and then we'll be able to answer the questions when the presentations conclude. Also, our colleague Kelsey Minix is our tech support amongst many other roles in the Cancer Center. You may call her or text her at 606-872-1322 if you have any issues with sound or the chat box or anything. At this time, we are going to go ahead and do brief introductions. It's always so nice for us to know who else is on who's participating in this program. So we would like for you to say your name, and if you're part of an organization, or if you would like to share where you're from, or if you're a cancer survivor, you're welcome to share that. And Kelsey is going to facilitate this part of the program.
Hello, everyone. My name is Kelsey Minix. I work at the Vanderbilt-Ingram Cancer Center, and I'm the program manager there. So as Ann mentioned, I'm just going to go through the participant list and call everyone one by one, as we find that that's the most organized way to go about this. So first, we'll ask Dr. Park to give a quick introduction of himself.
Well, thank you. I am Ben Park. I'm actually relatively new to Vanderbilt. Believe it or not, it is exactly 2 years ago. I started September 1st, 2018, and I came here after being at Johns Hopkins for 20 years. I co-lead the breast cancer program and direct precision oncology. And more recently, I am now the interim and likely to be, I think, permanent division director for the hematology oncology division within the Department of Medicine. And I'm a Komen scholar. I have really loved the organization and all that we do together, and that includes Komen, Central Tennessee with my new BFF, Don.
That's a great segue. Don, do you mind to introduce yourself, please?
Hey everybody, I'm Dawn Eaton. I am the executive, I can't even talk. The CEO of Susan Komen, Central Tennessee. I've been there for about 2 years and just delighted to be partners with Vanderbilt. So thanks for being here tonight.
Patty, could you please introduce yourself?
My name is Patty Lee, and I am a breast cancer survivor. And I also am the breast research advocate for our SPORE project, particularly on triple-negative breast cancer.
Claudia?
Hello, everyone. My name is Claudia Barajas, and I'm the Community Engagement Manager for Vanderbilt-Ingram Cancer Center. In my role, I work with the underserved populations and minority populations, and I'm very happy to be here with you today.
Allison? Oh, you're on mute.
I know that stuff. Thank you, Kelsey. I'm Allison Cutler. I work for Vanderbilt University Medical Center in the development department, and I'm the senior director of our donor engagement team. So I work with donors to the medical center, and excited to be here. I'm also a breast cancer survivor, and so I'm excited to listen for a number of reasons. So thank you for letting me be a part of it.
Julie? On mute.
I'm on mute. Hi, everybody. I'm Julie Bolger. I'm manager of patient and family-centered care, which includes the volunteer development program, which we are on hiatus with volunteers, sadly, right now. Support services, patient education, and the Patient and Family Resource Center. And I've been at the Cancer Center about 2 years and have been a caregiver and family member of somebody living with cancer, my sweet husband, for 25 years. So I am very grateful to Vanderbilt for the great research and treatment strategies that have come, because he is still here and doing fabulous because of the work that Vanderbilt does. So
Thank you. Elizabeth Hobbs?
Hi, I'm Liz Hobbs, and I'm in Brentwood, Tennessee. I work with Genentech. I've been a board member with Komen in the past and have several family members and friends with breast cancer, and I'm always interested in as to what's going on with research and in the community. So thank you for hosting this.
Lenise?
Hello, this is Lenise Campbell. I'm with Vanderbilt-Ingram Cancer Center, and I'm a health educator with focuses on African-American population and the rural population as well.
Thank you. Sylvia? If you're speaking, Sylvia, we can't hear you. You're on mute.
Sorry.
Okay.
My name is Silvia Franciscuti. I'm working in Grand Cancer Center. I'm working as health educator. I'm teaching the Hispanic people for cancer prevention. I'm so excited to be here. Thank you.
Jack Fetters? Okay, must not want to share. Okay, is there anyone else on here that would like to introduce themselves that I skipped over? Okay. Great.
Thank
Well,
you,
then we can transition into Dr. Park's presentation.
Yes, and so thank you, Kelsey, for facilitating those introductions. And I know Dr. Park told a little bit about himself, but I would like to add to his brief bio that tell you more. Dr. Park attended the University of Chicago for his undergraduate degree, followed by dual training at the University of Pennsylvania School of Medicine, where he received both his MD and PhD degrees. Dr. Park then trained in internal medicine and hematology oncology at the University of Pennsylvania prior to completing a postdoctoral fellowship in the laboratory of Dr. Bert Vogelstein at Johns Hopkins. Dr. Park, as he said, then joined the faculty in the breast cancer program at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins before coming to here 2 years ago today. Lucky us for sure. He is currently the Donna S. Hall Chair in Breast Cancer, Professor of Medicine and Interim Director for the Division of Hematology Oncology, co-leader of the Breast Cancer Research Program, and Associate Director for Translational Research and Director of Precision Oncology at our Cancer Center. His research program involves identifying and validating genetic targets for breast cancer therapy and diagnostics. In particular, Dr. Park has pioneered the use of liquid biopsies to help guide future management of breast cancer therapies. He has also led the formation and implementation of tumor boards at Hopkins and other institutions such as the Vanderbilt-Ingram Cancer Center. And certainly I'm the first to say too that Ben finds time always to participate and engage with the community, with our patients and families. He's one of the greatest advocates ever. And so Ben, thank you so much for being here, and thank you for sharing your expertise with us.
Thanks. And you should all know, for full disclosure, that I pay Ann a lot of money to say these nice things about me. Oh, that was great.
We adore you.
I really should hire you for my PR person. I'm going to share the screen. And again, it's a real pleasure to be here. And it's my absolute thrill to be sharing some of this stuff. I didn't know exactly in this relatively quick format, and I know it's 6 o'clock here in Central Time, so I didn't want to, belabor everyone's dinner plans, et cetera. So this is something that I was asked to comment on, and so I kind of modified the slide slightly for this talk about COVID-19 and how it's affected breast cancer care and research. And I'm purposely keeping this a little bit on the short side, one, because I talk too much anyway, so it'll probably be right on time if I do so. But then two, to give plenty of time for answers and questions, because I think, as was already mentioned, the pandemic is really unprecedented, and it has led to not only things like virtual Zoom conferences, but really has made us rethink how we can optimize patient care, and whether that's telemedicine, telehealth, or really thinking about, hey, what is the best way to control infections? What is the best way to carry out clinical research, laboratory research, et cetera? I think, many of us recognize this has been a tough year, but I like to say, if you're going to be an oncologist, you have to look at the glass 5% full, not 95% empty. So I've actually taken a lot of silver linings from this experience. And even though it has been horrific in many ways with all the deaths that have occurred, I also think there's lessons learned that we can grow stronger from this. So with that, whoops, I gotta minimize so I can see my own slides. All right. What do we know about COVID? So this is a brand new virus, so to speak. It's kind of probably hopped up from some sort of four-legged animal species. My dogs are looking at me funny right now. But this has been one of the most interesting scientifically viruses that we've ever kind of had to deal with in the history of humankind. Why do I say that? Well, things like Ebola, and other viruses, influenza, you generally will have a relatively short incubation period. So it becomes very obvious who's sick and who's infected. And so you can quarantine those individuals relatively soon. I think what has really been a very difficult part about COVID, and goes against kind of human nature of immediate gratification and knowledge satisfaction, is that we just don't know immediately when someone has COVID-19. There's a long, long incubation period. And when you think about evolutionarily, that's to this virus's advantage. People are walking down the street, they've been infected, they have it, they don't even know it, and they may be infecting people. The long incubation period has really been tough for this, because we don't know who's walking around that can infect people. The other part, and the second bullet point here, is that patients with this disease tend to really stay on the ventilator if they need to get intubated for weeks at a time. And that's very, very different than what we're used to in terms of ventilators and patients. Or, unfortunately, the patients will expire or pass away in the unit. Cancer patients are at increased risk. That's what we've kind of learned from doing association studies and kind of the epidemiology of this. Whoops, sorry. We don't know exactly why, but there's probably a lot of biological reasons, not only from cancer itself, but what we do to cancer patients by giving them chemotherapies and other therapies that will suppress the immune system. Some medicines have been shown to be effective. Hydroxychloroquine was not one of them, as probably many of you know, but we do have some evidence that steroids may be helpful. Proning is something that's a maneuver, not a medicine, but we turn patients and flip them so they're on their stomachs while on the breathing machine, and that tends to help because it redistributes the oxygen within the lungs. And then probably the most important thing, which I think we're all now aware of, is that masking and social distancing do actually make a difference. And so this is something, unfortunately, that I think we've learned the hard way of. We've seen people who have come to bars and restaurants and don't do that in certain cities. And then there's this big black box of what we don't know, and that's pretty much everything else. And this is so new. I was reflecting with someone when this first came out here, probably around the end of February, early March. We weren't even masking for every patient, and because we just didn't have enough masks, but because we didn't know. And I remember asking some of the infectious disease docs here at Vanderbilt, said, well, for cancer patients, I think we should be allowed as hemonc providers to do this. And they actually said no, I think, again, largely because they were trying to ration the supplies of masks and other PPE. But now we've gone, wearing masks, making sure we wear scrubs, wash them when we see patients wearing eyewear. So a lot of this is we're learning as we go along. And so that's the hard part as well. We just don't have a lot of data to drive us. How has this affected breast cancer treatments, both here as well as across the country? I have been part of conversations nationally with my colleagues in the breast cancer and just oncology world in general. And it's interesting because everyone is, again, learning as we go along. I don't want to say making it up because that sounds almost, you know, a little bit too harsh. But we are really taking our best educated guesses in terms of what would make the most sense from what we do know. And so trying to prioritize therapies, this has been something that I've been doing and my colleagues here at Vanderbilt. You know, it doesn't make sense to give chemotherapies first or surgery first when there's options to do one or the other. In other circumstances, and this actually happened with a patient of mine, a new patient, where we might not have necessarily thought about giving endocrine therapy first. This is a hormone therapy with drugs like tamoxifen or aromatase inhibitors, but this is a known and valid way to treat breast cancer up front before surgery. And that's something don't have to come to the hospital that frequently because we prescribe pills. That's what endocrine therapies are. And they can take it from home and then we evaluate them, you know, every month or more, depending on what type of responses we're getting. Immunotherapies have also been a question mark. Part of that is because when you think about what our immunotherapies are for breast cancer and other cancers, I should really say as well, they're training or unleashing the immune system against our cells and hopefully the cancer cells as well. But when you look at what that does to, you know, the immune system itself, it's revving it up. And so if anything, in theory, this might make a better immune response against COVID and other infections. So that's actually not the rationale why we would be hesitant to use immunotherapies in the COVID pandemic era. The real rationale is that because many of these immunotherapies, as I think some of you know, are actually going to have a lot of autoimmune side effects. Inflammation or itises.
Oh no.
Uh-oh.
Yeah.
Can you hear me?
Now we can, but you went away.
Oh. I didn't look at the light, thankfully. Hang on. It actually just said my internet connection's unstable. So maybe that's a big part of this here. Are you guys okay right now?
Yes.
Yeah.
Okay. Yeah, please say something if something's happening, or maybe hopefully I can get it. But I was going to say for immunotherapies, the real reason why we're hesitant to give them during the COVID pandemic is because if they have side effects, we give immunosuppressive therapies. And so there we're really worried, obviously, if you have a viral infection, COVID or any kind of bacterial infection, and you give an immunosuppressive therapy to offset the side effects of cancer immunotherapies, then you may in fact turn something that we call subclinical infection into something that's really, really bad. And again, we don't really know if that's true, but that's the theory. And so we've had to really be careful and watch very carefully as we're treating cancer patients, and in this particular instance, breast cancer patients specifically. There is no evidence that once therapies are completed and patients are fully recovered, that there is really any increased risk. So I've been asked this question many times. You know, I completed all my therapies a year ago or 5 years ago. Do I have to worry about being more at risk for developing infection of COVID? And again, we don't have hard evidence that that's the case. And we feel, for the most part, from what we do know, that that probably isn't the case. That said, patients who are on active therapy, so these are patients who are getting curative intent chemotherapies and other things, metastatic disease, that is where we're kind of concerned about. This may increase the risk due to the immunosuppressive effects of those therapy. Obviously, chemotherapy hurts the bone marrow as an example, and so your white counts are low, and that's why we worry when patients get a fever while they're on chemo. So the same rationale could be applied to COVID-19. So that's how we've kind of been approaching breast cancer treatment right now in therapy for during the pandemic. We're also, now that we have more testing, doing testing on a lot of asymptomatic individuals as they're getting, let's say, elective surgeries, for example, reconstructive surgeries, or if they're even getting therapeutic surgeries for lumpectomy or mastectomy. And then similarly, some of our chemotherapy regimens, we're doing upfront testing even if patients are asymptomatic. The harder part has been really also on research. And I say harder in the sense that even though our research and most institutions across the country, we had research shut down for about 2 months. That was both clinical and laboratory research. The effects on that have been more prolonged. And you can imagine we can shut things down pretty quickly, but starting things up has not been as easy. So the majority of clinical research was in fact shut down for March, April, and part of May. Most of our centers have reopened clinical trials completely now. This is in a graded fashion at first, Laboratory research is slowly reopening, and then again in a very measured type of way. And so we're only being allowed of what we call 50% capacity. So if your lab normally holds 10 people, you can really only have 5 there at one given time. And so what to do? I think, as I said earlier, the things we do know that work from other countries and even in our own country, mask, social distancing, is something that has really, really got to be front of mind. I'm a little bit worried because now that the undergrads are back, I've seen a lot of youngins, as I call them, not doing that. And so I'm worried about what's that going to look like a couple of weeks from now. Because remember, there's a long incubation period. I encourage everyone to talk with your care providers to understand what they're doing to mitigate the risks. I think many of you have seen at Vanderbilt, there's a screening process, there's questionnaires that are asked, there's temperatures, and then you have to wear the sticker. Believe it or not, I've talked to some colleagues across the country and at Johns Hopkins, for example, and they're not actually doing those types of things. So I was a little bit surprised about that. They are being a little bit more high tech to track people. And so you actually have to log in with your smartphone and then people know that you've logged in and entered a building. So again, there's different ways to do this. Above all else, I think using common sense probably is the thing that we should gravitate towards. If it doesn't make sense to do something, or it does make some sense to do something like social distancing and masking and wearing eye protection, then I think that's what one really has to do. And so, fortunately, thankfully, I made my slides short because with that technological hiccup, I'm not really sure what would have happened otherwise. And hopefully I didn't take up too much extra time, and I will stop sharing.
Oh, thank you, Ben. And that's great. And we do, I did put one question in the chat and I have a few more actually, but what we're going to do is have Dawn speak about Komen resources first, then we'll do all of the questions at the end. And don't worry, the timing's perfect. Absolutely. You did not go over your time at all. And so it is my honor to introduce our dear colleague and dear community partner, Dawn Eaton from Susan G. Komen, Central Tennessee. Dawn is a skilled entrepreneurial leader with a track record of achievement as a business builder, connector in the corporate, nonprofit, and government sectors. She has excellent organizational and strategic planning skills, which allow the planning, budgeting, and management of multiple projects at one time. She currently holds the position as CEO of Susan G. Komen, Central Tennessee, which is one of the 61 affiliate sites across the country working to save lives and invest in breaking research in the area of breast cancer. And speaking on behalf of my VICC colleagues, it is such a great joy to work with Dawn and the Central Tennessee team. They work tirelessly to raise money, to promote education and advocacy, and it is so wonderful that our teams can come together and really leverage our resources and our expertise without duplicating efforts. And so, Dawn, thank you for being here and thank you for sharing with everybody the wonderful resources that the Komen Foundation has.
Thank you, Anne. The feelings are mutual. So we're just delighted to be able to be here tonight and then also to share a little bit more about Komen. So can everybody see the screen? There we go. Can everybody see it?
Yes.
And hear me? Okay, great. So what I wanted to do tonight is just a couple of things. Again, trying to be quick and simple, but just to make sure that everyone knows a little bit about Susan G. Komen. So Susan G. Komen actually really started in 1980. And it started with a promise from one sister to another. Nancy Brinker was a sister to Susan Komen, and Susan was dying at a very young age of breast cancer. And really on her deathbed, Nancy made her a promise that she would try to end breast cancer. And that really became, the beginning of that became a reality in 1982 when Susan Komen organization was actually formed. So to date, about $2.9 billion has been invested in research, community health outreach, and advocacy. And between 1989 and 2016, efforts to reduce breast cancer, in part due to Susan Komen, have been reduced by 40%. So mission is simple. It's to save lives. And we do that in two ways. We really work to meet the critical needs in our communities, and I'll elaborate on that in just a few minutes. And then also investing in breakthrough research to prevent breast cancer, which Vanderbilt is such a major player in that field. And we're just delighted to partner with Ben and Ingrid and Ingram Cancer Center in that area. So Susan G. Komen Central Tennessee is actually one of 61 affiliates across the world. We serve 41 counties in Tennessee and Georgia. You can see the map. I know it's a little bit hard to see, but basically from the Kentucky state line all the way down to Chattanooga and 6 counties in North Georgia. What I wanted to do tonight is just to make you aware of the resources, which are many, very vast group of resources available on the Komen website. So our website is actually KomenCentralTennessee.org. And when you actually go to the website, one of the very first drop-down boxes that you'll see is called Breast Cancer Resources. And tonight, I just wanted to spend a minute and walk you through a couple of the things that are available through our educational materials. So we click on Breast Cancer Resources and then on educational materials. I've kind of divided this up. So if you were interested in learning more about breast cancer before you had breast cancer, these are some of the resources. So breast self-awareness messages, risk factors in education, screening and detection, and questions to ask your doctor.
Hi, Dawn. I'm sorry to interrupt you, but your audio is kind of shaky. Do you mind going off video to see if that makes it a little bit more clear for us?
Not at all.
Yeah, I think it may be unstable Wi-Fi, which we all understand.
All right, hold on just a minute.
Yeah, just stop your video and let's see if that makes it a little bit better. Yeah, not your presentation, just you being on camera. Let's see if that helps.
See if that helps, okay.
Yeah, but still sharing your screen.
Yeah, I've had similar issues as you all know, so I may turn off my video too.
Oh yeah, that's fine. Anyone, yeah, anyone. We completely understand that.
Okay, and let me know if that's not better. Thank you for letting me know.
Oh yes, and that's definitely better. So.
Okay. So what I thought I would do tonight is just walk you through a couple of these resources. So starting with risk factors in education, when you click on that link, as you can see, there are 7 or 8 different PDFs that you can click on to learn more about the risk factors. So I've just chosen one just to kind of give you an example. One of my favorites is Breast Cancer and Risk. It's a protocol brochure that we got. It's a PDF format. And so when you click on that, this is just one page of it. But I particularly like this slide and this brochure because I don't think people are really always familiar with what some of the risk factors are. Just had a conversation with a friend recently, and we were talking about risk factors, and she was completely unaware, other than being a woman and perhaps some genetic possibilities like inherited BRCA1 or BRCA2 gene mutations. She was unaware of some of the other issues. So alcohol use, just getting older, high breast density on a mammogram, lack of exercise. There's just a number of risk factors. And this is just one of many brochures that we've got on our website that people can download or just read on the website. So going back to that same place on the website, Breast Cancer Resources, educational materials, we've also got materials available for after breast cancer. So things like supporting after a breast cancer diagnosis, breast cancer treatment options, survivors and those living with metastatic breast cancer, and questions to ask your doctor. I, again, love this questions to ask your doctor. I just feel like, you know, we get overwhelmed with information when there's a breast cancer diagnosis. So in particular, when you click on that particular link, I've just circled a couple that I was going to share with you tonight. But the one, when breast cancer is diagnosed, what are those questions that you might want to ask? And we actually have a page that you can print out, and you can carry this with you to the doctor, and either you or someone that goes with you can write down the answer. So just an example, you have your meeting with your doctor right after you've been diagnosed. You can ask, what kind of breast cancer do I have? What stage is it? What type of doctors do I need to see? And you can write these answers down and then carry them with you, because chances are you're going to be so overwhelmed with information that you'll forget. Even if you thought to ask the questions, you might not remember the answers. So there are a number of these PDFs on the website that you can download and print. Another place that we have on the website is just information about clinical trials. Some of us maybe did not know what clinical trial was until COVID. We heard a lot about it because you have to have clinical trials before you can introduce a new vaccine, before you can introduce medications and treatments. So we actually have a place on our website where you can gather clinical trial information. You can actually sign up for a clinical trial just by calling this 1-800 number. In addition, under breast cancer resources, there is a whole section on metastatic breast cancer. So for those of you that are not familiar with metastatic breast cancer, it is stage 4. It is incurable, and it really presents a whole another level of issues that you might need to be aware of and to take note of. So we have an entire section about survivor topics. What if breast cancer returns? A lot of people experience lymphedema, so we've got a PDF on that. And then just some information about treatment and progress and what it's like to live with metastatic breast cancer. And you'll probably be hearing more about this in the coming, particularly coming year. Komen is reorganizing our helpline, and there's some more information coming out about that really soon. So it's pretty exciting, and some potential support groups around that. One of the other sections of our website is our community impact. So if you want to know, okay, I have raised money for Komen, and I'd like to know what they do with the money. I've done a little summary here for you. So just in terms of research, just the Central Tennessee, not the rest of the country, but just Central Tennessee alone, we have donated over $4.1 million to breast cancer research since 2000. Much of that has gone back to Vanderbilt, I'm happy to say, and again, we're just so proud to be a partner with Vanderbilt and the work that they're doing. In terms of community, as we raise money, we actually put that money back into the community and put that money back into direct services. So we've given more than 397 grants to community partners since 2000, and that has totaled over $10.1 million. If you wanted to know who our community partners are and our mission partners, again, as you can see at the top of the page, there is a link called Community Impact, and you would click on Mission Partners, and these are our current partners for this year. So in 2021, we have partnered with Ascension St. Thomas, Tennessee State Government, the Breast and Cervical Screening Program, and the CHI Memorial Chattanooga area, primarily for screenings, because we know when people get screened and the earlier they can be detected, the more likely they are to be able to live this disease. And this is just a close-up, so if anybody actually wanted to take a picture of this and get a free mammogram, all of these places offer free mammograms. And this is just a picture, and I think that probably, Kelsey, maybe we can put this in some of this even in the chat box a little bit later, or provide this at a later time. We also have a program called the Susan Komen Treatment Assistance Program. So for those women and men, if men and men can cancer, breast cancer, they can actually take advantage of our treatment assistance program if they are in active treatment and if they meet certain criteria, particularly along the income level. and it's usually primarily for lower income, uninsured individuals, but they can get up to $300 a year for things like oral pain medication, child care, transportation, things that would not be covered by insurance. And again, this program is also being revamped nationally, and I think that you can expect to see some additions here of some other services that are going to be offered, as well as more than $300. And last but not least, I'd love to invite you to participate in our walk. Join the fight with us. Walk with us to find a cure. You could do this in honor of a loved one that's still living, or perhaps even in memory of somebody. So we actually have 2 virtual walks this year. One in Nashville will be celebrating on October 3rd, and the one in Chattanooga will be celebrating October 24th. And in order to register for the walk, it is free. But in order to register for the walk, you can go to Komen, centraltennessee.org. And I think Kelsey is also putting that in the chat box. Or you can take out your camera and take a picture. But either way, start a team and join us, because now hopefully you know a little bit more about some of the resources that we offer and actually what money is used for. So that's the end of my presentation, and I thank you for that opportunity.
Thank you, Dawn, for sharing all that information. And I want to put a big plug in for Team Vanderbilt. We have a team for the walk on October 3rd. And so we are beginning to really promote it and to engage our faculty and staff. And we would welcome any of you to be part of our team. We're always very proud to be part every year. And virtually, I know this year it's going to be wonderful. So at this time, we are going to open the mics and the chat room, and we are going to have some questions. And Claudia Barajas is going to facilitate this part of the program.
Thank you, Annie. This is wonderful presentations, and we have 3 great questions in our chat. And the first question, it could be for both of the speakers, and is, what do you think will be the impact on decreased screening during COVID-19 on breast cancer incidence, mortality rates, long term?
I'm happy to start off with that. Can you all hear me okay?
Please, yes.
Okay. You know, I'm hoping it'll be minimal, because the screening, even though it was stopped for a couple of months, we have resumed this. And I think that the longevity of this has not been so pronounced that I think it'll have an impact on actual screening mortality. You know, we like to do obviously things annually, but I think many people who do this, sometimes we're off by a month or 2. So I don't think that just a couple of months of us being completely shut down is going to have a huge or tremendous impact on this. I don't know that for sure. Time will tell with the data, but I'm very kind of cautiously optimistic that that's not going to have a long-term impact, thankfully.
Yeah, wonderful.
Thank you. So the next question is specifically for Dr. Park. How do you think funding from the National Institutes of Health, National Cancer Institute for Breast Cancer Research may be impacted due to COVID-19?
Yeah, you know, I would even extend that beyond the NCI and NIH, that I think all funding agencies have really felt this effect. Our whole economy has had a downturn, which I think we all know and recognize. And, you know, there have been, unfortunately, foundations. Komen has been affected, where, you know, investigators wrote grants. I serve on study sections for Komen. We held those study sections, and unfortunately, we just could not fund this year's grants. Similarly, other foundations have cut down on the amount of funding they've had, and this has also been affected at the NIH, NCI level. So it has, unfortunately and unequivocally, I think, made an impact in a negative way. But again, if you're going to be an oncologist, you got to look at these kind of challenges as opportunities. So I actually think this presents for us a way looking forward. We have to think of ways that we can be more self-sustainable. And I think one of the things that we're trying to do as a cancer center and as a medical center in general is to think about how we can actually start to really raise funds locally and be a little bit more proactive about that. And I don't mean that to mean that we're just going to go out there and knocking on doors. We want to develop partnerships. You know, this is the one thing Dawn and I are so aligned with. raising money for breast cancer research and other cancer research is more about than just writing a check and then handing it over to someone. It's about developing relationships and making sure that everyone who contributes knows where their hard-earned dollars went. And so that's where I think our opportunities are going forward.
Mhm.
Thank you very much.
Dawn, did you
And-
have anything to add to that? I didn't, we want to, oh, okay.
My speaker's broken.
Okay.
One more question. Any efforts or ideas for recruiting more minorities into clinical trials?
Yeah, I don't know about, well, I'll be honest with you. I think that this is something that we've all struggled with, and it's not just related to clinical trials. It's for the whole enterprise, from recruiting talented trainees, faculty, et cetera. And one of the things that has really come up with all the travesties and tragedies that have occurred across the nation, from George Floyd and now more recently with the Kenosha, Wisconsin incident, is it's enough. We've had it. There cannot be complacency in this anymore. And many of my colleagues and myself included in this have decided that we need to think more about how to fight this complacency. So one of the things I've been doing as the interim division director is addressing this head on. We're assembled a band of really dedicated individuals, including underrepresented minority trainees, and thinking about what are ways that we can address this, what are our metrics of success, and what are our goals. And it's, again, increasing minority recruitment to clinical trials, trainees, creating a culture and environment where Black Americans, for as an example, don't feel like they're threatened to go out on a jog in the morning. You know, this is something that has just really taken front of mind and my own personal views, huge importance. So our recruiting efforts right now, we're actively going to look. Some of the trainees that I've talked to told me, you know, there's a lot of local talent here with Meharry and other southern states. Why don't we try to recruit for them? And so we need to do that. And that's what we also need to do for our patients, to try to get them on clinical trials. So the efforts are things that we're planning on right now. I mean, we've always tried to do this, but I think this has taken new priority. And one of the things that I think we're all trying to fight against is complacency. That's what I think has always happened. We hear these events, we feel horrible about them, we want to do something, and we have this heightened awareness, and then we get complacent because time has kind of just erased that memory. We can't do that anymore. And so that's where I think, you know, I like to quote Coach K from Duke. I hate Duke because I'm not from there. And if you're not from Duke, everyone hates them. But he is a great coach. And one of the things that he said when he spoke up against this is that the cadet's prayer says, Lord, help me do the harder right and not the easier wrong. And I'm trying to live by that example right now, because I think that that's what we've all been kind of guilty of. We need to do the harder right and work more to increase minority recruitment to everything.
Wonderful. I'm glad to hear that you are on top of that effort. Something that I would like to add is that we at the Cancer Center have been partnering with Meharry Vanderbilt Alliance, and we have been creating education opportunities about the importance of participating in clinical trials for Latinos and African Americans, and that's planting the seed, no? At least providing the education and creating the awareness. But the distrust is so huge in those communities that a lot of efforts have to work at the same time.
Absolutely.
Thank you very much. We have one more question for Dr. Park, and is, how are your patients responding to telehealth visits? And do you foresee this as a way to care for our patients, and who will continue beyond COVID?
You know, the unequivocal answer to that is yes, and absolutely. Patients have loved this because it really has become the new house call, or the modern house call. And I think some of it we should be doing more of in ways that I've seen other institutions as an example. You know, a lot of this right now, the criticism is, well, you know, you can't do that much of a physical exam. You can do the observation part, but you can't do some of the stuff like listening to the heart or examining things. And it turns out you can, but you just have to be creative and look at the tools that exist. As an example, many dermatologists now are having patients use their cell phone and taking pictures and then sending them in real time. the other thing that people have showed me, and I feel like I'm super old because I didn't know this exists, but there are now Bluetooth stethoscopes where a patient could actually put their stethoscope on their heart and their lungs, and then it gets transmitted over the internet via Bluetooth to first their computer to the Bluetooth, and then over the internet to the receiving provider or physician. So there's a lot more I think that we could really do using telemedicine, telehealth. And I think a lot of patients love the fact that they don't have to wait in line and sit there in the office with you know, to wait for the physician. I do think the challenge is going to be, believe it or not, the payers, Medicare, Medicaid, insurance providers. Right now, they've kind of given us a lot of leeway because of the pandemic, and it's not clear how much that leeway is going to last beyond this. We were really focusing on this effort anyways at Vanderbilt. My precision oncology team, we're set to do a precision oncology second opinion clinic in Knoxville via telemedicine. So I think what has happened, COVID has really catalyzed this whole effort, but there's still going to be a lot of questions remaining in terms of billing because of the third-party payers, and then licensure. The way that state licensures are set up, this doesn't make any sense to me, but it's not where the provider is, it's where the patient is. So we have now gotten temporary licensures in Kentucky, Alabama, some of the surrounding states because of the pandemic. But if we have a patient in Florida, we can't see that patient unless we're licensed there, technically and legally. And, you know, some of my colleagues and I are like, this doesn't make any sense because it should really be where the provider is. This basically means that if that patient were to come to Tennessee, but if I happen to be on vacation in Florida, I could still see that patient legally. Makes no sense. I'm not licensed in Florida, I'm licensed in Tennessee. I mean, that's where I think we're gonna have to work this out as a country and a nation.
Okay. Thank you, Doctor. I see a comment from Patty regarding Faster Together. Patty, would you like to add something about the wonderful program?
Well, this is about my job, and the work group I'm in is the Center for Knowledge Management. And we worked with Dr. Consuelo Wilkins on Faster Together. And the whole idea of helping, whether you have recruited lay people in the community or whether you already have clinical people to recruit, they need special skills and sensitivities. And so there was just, there's a tremendous amount of work that has been done. Some of it has been found to be very counterproductive, like the whole concept of being colorblind. And this was actually something that was promoted by HHS and NCI, that we should all be colorblind. But the truth is that we need special sensitivities because we have to first create trust in the community. It is, it's such a big deal. So in other words, we created with it has video and it has questions, it's interactive. We created a course on Coursera for anyone to use if they're trying to sensitize staff to help them understand how to talk to and be sensitive to other cultures without, you know, to get them to trust us to enter a trial, you know, because we need those people. We need people of all backgrounds in our clinical trials to make the results more generalizable. It's really a huge problem and a big need. So when you ask that question, and Ben was talking about it, everything, and I'm sure all of you know about this, of creating community boards, advisory boards, and recruiting minority providers and having those people understand, appreciate, and buy into the goals of the trial. So anyway, it's about after we did it, and it was all put together. I was one of the testers, okay, that went through it and did all the activities. And I will tell you, it's about 15 hours. I mean, it's not, you listen to, you know, videos and read things and go to websites and stuff. It was quite a big deal. Okay, I don't know whether anyone in VICC has looked at this or, you know, at all.
Thank you, Patty. I have had that opportunity. Thanks. So with this conclude our question session, and I'll pass it over to Annie.
Okay. Well, thank you again, Dr. Park and Dawn. This has been so wonderful, just so much wonderful information and resources. And throughout the year, and especially during COVID now, we're doing a lot more virtual programs. All of our programming is virtual, and we are being very intentional to update our events calendar on vicc.org/community/events. And so that's a great way to keep abreast of everything we're doing, but also through social media. We're trying to reach people from all over through Facebook, Instagram. And so here on this slide, you'll see Komen and VICC's different handles. So thank you so much. And I hope all of you remain very safe, and we'll be in touch again soon.
Thanks, Ann. Thanks, everyone.
Thank you, everybody.
Thank you.
Thank you. Thank
so
you.
much.
Thank you, Dawn.
Bye.
And that was so interesting. Thank you all.
Thank you, Julie.